Good evening, everybody, and welcome to the February 4th Board of Directors meeting for Windsor Regional Hospital, the open meeting. I'm going to call the meeting to order. Can I get any declarations of conflict of interest? Seeing none, thank you. Can I get a motion to approve the previous minutes? I have Paul Lachance, seconded by John Leotowicz. Questions or comments with regards to those minutes? Seeing none, all in favor? That's unanimous. Thank you very much. So we're going to move right into the report of the President and CEO. David.
Thank you, Mr. Chair. I will pop up on the screen a presentation. There we go. Okay, thank you, Mr. Chair. I want to highlight three items tonight. One being influenza update, kind of where we sit, because that's always a common question that's asked. Then I'm going to talk about the COVID variants, and then also the status of the various vaccines that are available not only in Canada, but worldwide, and where we sit as Canada with respect to our procurement efforts moving forward. So first is the good news, is influenza update. You'll see from these charts, it's quite fascinating. The chart on the left indicates the number of influenza tests. So the red line is the tests that have been performed for
David, can you hold up 1 second? Sorry, you're just not moving through your slides. So I think you've moved out to slide 2.
It looks to be frozen. Just restart your end your screen share and restart it, please.
Oh, really? Like it's frozen, like I was supposed to stop on this slide, right? No?
We're not even seeing your presentation view.
Oh, I get you. Let me try.
Oh. Now it's up.
Interesting. I got a black screen. Is it up now?
No, we are seeing your working view. Can you completely turn off your end screen sharing and restart?
Stop share. Okay. And you're saying restart it?
Yes, please. Thank you.
I'd say we've done fairly well so far with regards to technological hiccups.
No?
No, exit your slideshow.
Yeah.
And just run it from here. Run it like this screen is how you'll have to do it.
Oh, okay. Interesting. Do you see it now?
Yes.
Son of a gun, whatever that is. All right, well, thank you. With this slide, you'll see on the left-hand side, it's the number of influenza tests that have been performed in 2020, 2021 from the surveillance period. And you will see it starts at the end of 2020 and works its way into early 2021. And as compared to even previous years, the number of tests we performed for influenza is much higher this year than on average in previous years, or the collective of all the previous years together. And then the slide or the chart on the right shows the actual percentage of tests positive for influenza as compared to previous seasons. You'll see the dotted line in the middle of the gray area is the average, with the range around that average for the last period of years. And then the red line, which is flat right along the bottom, is the number of actual percentage of positive influenza tests. So to date, with all those tests, so if you look at it on any given month, I mean, there's close to 20,000 tests right before the end of the year, and even 16,000 as recent as a couple weeks into this year, in the middle of January. We've only had 56 influenza detections have been reported. And in the last 6 seasons, it's averaged 21,106 to date. So by this time in any given year across Canada, we've had over 21,000 influenza detections with less testing. This year, we have had only 56, which with a considerable amount of more testing. So before I pass it, Dr. Saad, to give his clinical ideas here, clearly something's working, something's different. And it is interesting as we move forward, when we start exiting COVID, we know how we can greatly impact influenza. So I don't know, Dr. Saad, if you wanted to comment regarding these numbers. You might be on mute.
Oh, thank you. Yes, I agree, David. The two things that come from this are, number one, it is very clear that the public health measures that have been put in place to stem the tide of COVID is much more effective at preventing influenza transmission. If you look at it, it's not just a matter that people are not testing for it. We're clearly testing just as much as we were in previous years, but the number of infections is significantly down. But what this also tells us is that the coronavirus is much more difficult to contain, as is influenza. So if we ever had an influenza outbreak where we needed to, quote unquote, flatten the curve like we did, clearly we could be very effective at it and practically knock it down to single digits or double digits. But unfortunately, that's not the case with coronavirus. So that's what this graph tells me is two things. Number one, we can, for future years, prevent flu outbreaks very effectively if we follow public health measures. And number two, the coronavirus is a nasty virus, which we already know, and that despite our attempts at stemming the tide of infection in the community, it still seems to rear its ugly head.
Yeah, thank you, Dr. Saad. Yeah, it is fascinating. And so if there's going to be, quote, something positive coming out of COVID, this is going to be one of the items that will be positive, is we know we can address influenza outbreak in future years as we move forward. So thank you for that. The next item I'm going to highlight is the COVID variants. We hear about this across the world, across Canada, about the variations that have developed, or the mutations of COVID-19 that have developed from the start. And what's the word you use, Dr. Saad, to describe the underlying virus? It's called has a name for it. Not, you have
it's
the variation.
wild. It's called the wild type.
The wild type is the current virus. So if we look at the far left, the D614G variant, that's the variant that emerged rather early.
David, you're stuck again. Sorry.
Huh. Wonder what's going on.
All of our viewers at home are like, I don't understand what he's doing. So, there we go. Nope, you're up now.
Yeah, but it's not the full screen, right?
Yeah.
There. You see it now?
1, 2, 3. Yes, we can see it. The only thing missing is maybe a sentence.
The bottom part? Yeah.
Yeah.
That's me. That's my editing. Sorry.
Okay.
That's
No
me. I
Thank
just
you.
noticed that myself as well. So the one on the far left, I'll speak quicker because clearly the screen doesn't want to cooperate. So the one on the left is the current strain we're dealing with now with respect to COVID. It came out technically early January, February of 2020. And it was a mutation that was identified from Toronto, and it is the main form of the virus circulating around the world by June of this year, and saying it was more infectious and easily transmittable than the original, even though it didn't make individuals sicker. And then we heard a lot about the UK variant, which is the one that started, of course, in the UK. It was found in the UK. It was 60 to 70% more transmittable than the current virus. And until a couple weeks ago, it was thought that it was not as deadly, or it was equally deadly as the current virus. But they found that that was not the case, that they're seeing it is more severe than the current virus, the current strain, but also it has the impact of the fact you have a greater percentage just being infected with the virus. Of course, then, as we know, what happens is the greater number infected, the greater number hospitalized, the greater number in critical care, and unfortunately, the greater number that die. So when you start with a larger number in the first place, those percentages, of course, are larger in any event. So even if it is equally deadly as the current virus, the fact the numbers of those infected increases by 60 to 70% is dramatic. And there's the one home, a long-term care home in Barrie, where unfortunately this was heavily infectious. And I think the number is approximately 130 residents lived at Roberta Place. And so far, over 60, I think the number is 63, have passed away. And that all happened within the last month. The first positive case was recorded, I think, on January 8th, and it's only February 4th. And it had that big of a devastating impact on that long-term care facility. With respect to these variations or variants, this passed on January 20th, the testing for it is more complex, and it takes a couple weeks to get results back. So it's not automatic. When you get a positive PCR test, they have to do further testing to determine if the variation is present. So on January 20th, Public Health Ontario did approximately 1,900, just under 1,900 tests of those positive, further testing, genome testing, to find out if the variation was there. And out of those 1,880 positive samples, they found 103, or 5.5%, were either the UK variant or the South African variant, which I'm going to talk about next. 89 of them were from the Simcoe Muskoka Public Health Unit, which relates to Roberta Place. So other locations that generated the variant on that January 20th was Peel Region, had 6 cases, Toronto had 5 cases, and York, Waterloo, and Durham all had single cases. We have sent up some of our positive results to get this testing, although it's limited. We have not heard if the UK variant, or the next one, the South African variant, are present officially in Windsor, Essex. However, the concern is these variations will become the dominant strain in March in Ontario. And that's why there is a lot of hesitancy, is we're very comfortable or happy with the fact that our cases are going down. Looks like community transmission's going down. Our admissions today, we still, I think, admitted 4 to 5 new positive patients with COVID. So that wasn't good news today that happened. But our overall numbers have gone down, or have steadily gone down. Our recovered cases are going up, of course, which is good. The hesitancy or the concern is the presence of these variants and the impact, how quickly they can spread. Just looking at Roberta Place, how quickly the tide can turn. And there's a lot of discussion out there right now that one of the ways you eliminate variants is you stop replication. The way you stop replication is with vaccines. So if you can vaccinate, you stop replication, then you reduce variations because the variants feed off of the replication of the virus in the first place. The more it's replicating, the more chance that it is mutating. So again, South African is been found in Canada, been found in Ontario as indicated. The concern with South African is the impact that the variant has on a higher viral load, making it potentially more infectious than other variants, and also making a concern regarding the efficacy of the vaccines on that South African variant. So far, it seems the UK variant, the efficacy of the vaccines is still very strong. However, the South African seems to impact the potency of the vaccines, and Moderna is looking at even a quote booster shot in response to this. Brazil, I'd sent out to the organization, Anthony had sent it to me, with respect to the impact of Brazil and the Brazil variant. And last year, as you recall, Brazil was hit hard with COVID to the point that they had estimated some 75% of their population was infected with COVID at one time. And in effect, they created herd immunity by being infected with COVID. And they were very comfortable that because of that, that they had now survived the bad part, and they had started opening up the country, started opening up activities, and things were getting back to normal because they thought they had conquered COVID by way of herd immunity, by way of some 75%, 76% of the population having become positive. Now, the Brazil variant has struck, and a good percentage of their population now is positive again. The same who were positive previously. So very concerned about that. And then there's one that is called the Denmark variant. And again, very similar is they're very concerned about the impact of future vaccines with respect to this variation. And Denmark was very similar to what Ontario was going through, where things were going up and then they dropped dramatically. They thought everything was fine. A lot of pressure to open up the economy. Denmark hesitated, a lot of strife amongst the residents in Denmark. And then unfortunately, bam, they got hit again with COVID and created some issues in Denmark. So those are the quote variants that are out there now. And that is our nervousness. If you listen to some of the scientists, clinical experts out there, they say this point in the pandemic makes them the most nervous. It is a lull. They've given it the analogy of the quote, eye of the storm, meaning everything's calm, but it's about to hit us. Or they give the equivalent of like a tsunami where the water's rushing out, you feel everything's fine, and all of a sudden there's a big tidal wave coming at you. And it could happen fast. So one of the items we look at is our assessment center and the volumes coming through there. We were having 600 to 700 people swabbed a day at one point, not that long ago, just before Christmas and through Christmas. And then it dropped off dramatically. Now, if we get 250 people through a given day, that's a big number. So one of the items we're looking at is that, and that's going to be the item early trigger. If we start seeing that number creep up to 300, 350, 400, that's going to be some alarms and bells and whistles going off to us that our community is coming back to get swabbed because they're symptomatic. And that is going to be very, very concerning. So in the meantime, with all of this going on, we are trying our hardest to increase our day surgeries, even our inpatient surgeries. We're doing our best, working collectively, being cautious at the same time and recognizing this thing could turn on a dime really fast, and we have to be able to react very fast. So it's quite a balancing act right now. I don't know, Dr. Saad, if you wanted to talk about variants or surgery.
Thanks, David. No, I think you summarized it well. During this lull, we have to do our best to try to get as many patients through our surgical department, not just the outpatients, even some that require inpatient surgery, because this is the most critical and what we call vulnerable time in the pandemic. Whether we're going to get a wave 3 or not really depends on how effective our mass vaccination program is and how much we, as you exactly said it, if the virus doesn't replicate, it doesn't have a chance to mutate. And these are variants that are becoming very dominant in the regions that they arose from. And because of some international travel that's still being allowed to happen, they're taking hold in other areas as well. But that also doesn't mean that we're not going to get our very own Ontario variant because of replication and spread locally. So that's why it's very critical to continue with those public health measures until the mass vaccination programs are done.
Yeah, do not want a variant named after Windsor, Essex. So we shall see. The last item I'm going to talk about is vaccines. Needless, I won't go into what's going on with vaccines. That's pretty well known. We have a limited amount. But the different types of vaccines that are out there and some of the progress that's being made. So, of course, everyone knows Pfizer,
David?
Canada. Nope, once again.
Sorry. Yeah.
I tried something new with something and I'm not trying it again.
Okay, you're set.
Okay. So thanks, Anthony. Pfizer on the left, it talks about its efficacy, 95%. Now, the testing that was done on Pfizer was done before the variants really took hold. So there is some discussion regarding really, if you retested Pfizer now, and I think they are, would you end up with 95% efficacy? That's a question we'll find out as it unfolds, because especially Johnson & Johnson and AstraZeneca did their testing when the variants were taking hold. So their efficacy, of course, is less on the far right. Pfizer, again, 2 vaccines, 2 doses. It talks about its availability. It's available worldwide. Canada has purchased up to 76 million doses. Wish we had a lot of them. We don't. We are to get more near the end of this month, and they had promised they're going to reach their target by the first quarter, so we'll see what happens. Moderna is the one that's being used by public health for long-term care retirement homes. Again, 94.5% efficacy. As indicated, the South African variant seems to impact it. They've done some studies themselves. It's still effective. They're looking to see whether they need to create a, quote, further booster shot to overcome the South African variant. So that's what they're working at. Of course, Pfizer stored at -80, Moderna stored at -20. And Canada has purchased up to 40 million doses. But again, some issues with respect to receiving even Moderna. Novavax has gotten some news lately. That's the one Canada has worked out an agreement for them to actually start manufacturing Novavax in Canada, I think in Quebec, but it won't be up and running until the fall. They're actually building the plant as we speak, from my understanding, and that won't be done till summertime. And then it won't be able to produce vaccines out of that plant till fall. Canada's again bought up to 76 million doses, 2 shots again, 90% efficacy. has some issues with respect to the UK and South African variant, again, dropping its efficacy down. But the great thing about Novavax is you can store it in a basic fridge. The same for Johnson & Johnson. The beauty of Johnson & Johnson is it's one shot, one dose. You don't require 2 doses. It does do well with respect to preventing severe disease and also preventing hospitalization and death. Does a little less with respect to preventing symptoms, meaning 66% efficacy as to symptoms. But overall, it's generally okay with respect to its efficacy. Again, basic fridge. Canada's bought up to 38 million doses of that. It is early this month. It's going to be, which is February. They are presenting their efficacy data to the FDA and hopefully getting approval for emergency use authorization. And then finally, the AstraZeneca, again, 2 doses. It appears to do well with the variations UK, but data is still being collected. Again, basic refrigeration. And phase 3 trial was completed in fall of 2020. The vaccine's being distributed in the European Union, although I heard even today, I think it was Germany and now France has indicated that they are not recommending AstraZeneca to people 65 and older, as their studies have indicated that it does not do as well with respect to that age group. And Canada's purchased up to 20 million doses of that particular vaccine. So those are just some of the highlights of the ones that are in the market or about to go on the market. And here's kind of Canada's list of all the vaccines that they've purchased. Needless to say, we have 34 million, 32 million people in Canada. We have purchased a significant amount of vaccines total to vaccinate our population. I've heard 5 or 6 times over with double doses if all of these vaccines make it to the market. So we are restarting our second doses February 8th. We are hoping to receive more Pfizer on February the 15th. And that's the hope. And also February 22nd. And hopefully we're at a point where maybe we can start first doses again around the 8th or the or sometime around, past the 15th, once we start getting a flow of vaccines. And there'll be more coming out with respect to the provinces. I think they're still looking at possibly modifying the phases in the sense of the populations under each phase. So we'll see where that unfolds over the next 48, 96 hours.
David, we just have, we have a quick question from Patty.
Yes, go ahead.
Thank you, Mr. Chair. Dave, actually, as you started talking in your second part, you answered it. My question during your first part of your presentation was certainly vaccinations will help stop mutations, but does the vaccination stop if the mutations have, or are they effective if the mutations have already impacted us? And it sounds like you're saying maybe. Stay tuned. R&D is still out there. That's what I'm hearing you say, but I'm not 100% sure. So I'll leave that with you.
Yeah, I think I'll hand it off to Dr. Saad, but Dr. Fauci said this when they talked about some of them dropping to maybe 60% efficacy as a result of the variants. He said it's better than 0.
Okay.
So that's what he's looking at. And he's looking at also if it can prevent serious illness, hospitalization, or death. Yes, you might become symptomatic, you might get sick, but not to the point of having to go to the hospital, not to the point of dying. Okay. That's what we're trying to prevent. So, is it, again, and even with Pfizer, it's 95%. Is it really 95% when you compare it during the same timeline that the AstraZeneca and the Johnson & Johnson had to be tested in? as compared to when Pfizer was tested. So I don't know, Dr. Saad, do you want to talk about vaccines?
Thanks, David. I think the 2 points that you made are very important. Number one, any efficacy is better than no efficacy. And just to put things into perspective, because we all sort of expect perfection and why are these vaccines not 100%? We know nothing's 100%, but a typical flu vaccine year after year is between 40 and 60% effective. Yeah, we recommend it for everybody. We get it ourselves in terms of healthcare workers to try to prevent the transmission. And it's basically a coin flip, 50-50, whether you're going to get, whether it's going to be effective or not. None of these vaccines actually fall below the efficacy of the flu vaccine. And again, I sense disappointment from people in the media and people saying, oh, it's only 80% effective. We would have been very happy with 60 or 70% effectiveness when these vaccines were first being trialed. So that's the first point. And then the second point is also very important, is if you end up with a runny nose or a sore throat after you get vaccinated because of COVID, I think most people would take that. The main reason why we're doing these mass vaccination programs, even at lower efficacy rates, is to prevent hospitalizations, prevent deaths. And they do achieve that right now as of the new variants that we're aware of.
10 months into the pandemic, I don't know how to use Zoom yet. We had a comment from Lori Freeman.
Just kind of a follow-up on our question, on my question at our last meeting. So they are beginning clinical trials to combine the different vaccines to see if you can get one type of one vaccine and then get another one and still have efficacy. So somebody out there must have heard us, and they're starting those trials. So that will be good, because then if we have issues with production of one vaccine, we can still continue with the second one.
Yeah, and I think the trials are Pfizer and AstraZeneca, combining the two of them and seeing the impact of that. So it'll be interesting if they're able to differentiate between that clearly, the impact of Pfizer. Does AstraZeneca give a boost? Yeah, it'd be fascinating. And again, the environment in which it's tested. But you're probably, better off with one, I won't say that, one dose of Pfizer, and then, what AstraZeneca does, it does. But don't quote me on that, anybody. I don't want to be quoted on that, but it'll be interesting. I don't know, Dr. Saad, you're mixing and matching.
I was laughing at your comment. No, you're right. Again, and part of this has to do with the global supply chain. I mean, if Pfizer was able to continue to produce their vaccine, I don't think anybody would have been tinkering around with these combinations. But the immune system is very complex. We don't know for sure whether these combinations are going to work or not. So we are going to wait for the results of those trials. And if they do work, then great. Well, that'll be another option if the supply chains are cut again.
Yeah, it'll definitely make things easier for everyone, but we'll see.
David, were you done with your presentation? Sorry.
Yes, I was done. Just questions now. Yep,
okay,
all done.
Perfect. Seeing questions, anybody else? All right, no, I think we're okay. I just have one question, David or Dr. Saad. What is the period of time between your second dose and then you needing a booster? Do they have any idea with regards to that yet?
Take it, Wasim. I assume the Moderna, they haven't started the boosters yet, but.
Yeah, so it usually takes at least 3 to 4 weeks for an immune response to happen. So you get your first shot. Most of the vaccines are given between 3 and 4 weeks later. Some are up to 6 to 12 weeks later. And then you reach quote unquote maximum immunity a week after your second dose. The experiments they're trying now with a third booster to try to combat the variants is another 4 to 6 weeks after the second dose, if that answers your question.
Yeah, and I think half of it. So going forward, are people looking at getting a booster every 6 to 9 months for the foreseeable future?
Yeah, no, there's no, unfortunately, we're not going to be able to tell whether the vaccine is effective after your second dose. There's no blood test. Even if we did serology to check your antibody levels, it wouldn't be helpful to tell us whether you're actually fully immune or not, because you could have negative antibodies and be completely immune, and you could have antibodies and may not be immune. So there's no real way to tell. So there is no plans to give people a third dose unless, again, we're dealing with a variant in the community, and that's the only option that we have.
Okay, thank you for that. Appreciate it. All right, if there's no other questions, we are going to move on to Dr. Jacobs with the Schulich report.
Thank you very much, Mr. Chair. I have a very short report. It is attached. I actually just want to highlight one bit of good news, if that's okay. The Canadian Association for Medical Education has named Dr. Alice Chu, one of our eMERGE physicians, as a recipient of a national award, the Certificate of Merit. It's a pretty prestigious recommendation, and so I just wanted to bring it to this level so that all of you are aware as well. So congratulations to Dr. Chu. Other than that, it's status quo. We're moving along with the school, and now that the hope is that we'll be able to get this year wrapped up as cases are coming down without any more hiccups, touch wood, but no other updates for right now. Thank you.
Thank you, Dr. Jacobs. Next up, we have Penny Allen with the financial report and presentation.
Okay, can you hear me now? No.
Yes.
Oh, you can. Okay, good, good. Yeah, it wouldn't unmute, and then all of a sudden it would. So anyhow, yes. So the first slide is the hospital operation funding and financial report. The year-to-date deficit for the hospital operations is $3,855,000. And that's a deficit, and I'll just do some of the highlights here. And then the revenue is 10.6 million favorable year to date, but that's because of funding from the government, basically. That's a part of it anyways, to get the money for the expenses for COVID. The total expenses are 18.1 million unfavorable. Largest variances is salary and wages. The COVID-19 unfunded expenses date in the amount of 7.8 million. The last two pieces of information on this slide is quite important. One is the deficit after you have the building amortization in it, and it's 5,525,000 negative deficit there. But it should be noted that if the unfunded COVID-19 expenses had been funded as incurred, the year-to-date surplus would have been 2.3 million and the hospital margin 5 million. But as I've been told, the people in Mark's staff and him send out reports to the ministry to get money for the expenses that have been incurred, but it takes a while to get that money back. So there's a timing thing in there. So and it's going to stay that way, I'm pretty sure. So the next slide is we have received for COVID-19 operating expenses from April to September in the amount of 13.3 million plus 7 million for the pandemic pay. Reimbursement of August and September operating expenses was received in December. So that was good. Generally, there has been a 2 to 3 month lag in the ministry reimbursements, which is what I said in the other slide. Yep. The decreased patient services revenue are mainly diagnostic revenues, which are 11% below the target to date, and preferred accommodations are also 7.8% 76% below the budget. A lot of that has to do with COVID and people who can't even, can't do elective surgeries or things like that. Next slide is the base and one-time funding is 10.3 million favorable to date, while revenue for quality-based procedures are lower than budget by 8.2 million due to the reduction in elective surgery cases. One-time funding is higher than the budget by 17.6 million, as this is where we report the ministry reimbursements for the COVID-19 expenses. The quality-based procedures have to be deferred because you need the beds for the COVID, and that's you can't upset how that happens. The next one is the other patient services is unfavorable. Drug ministry reimbursements are favorable, and other recoveries are favorable. Okay, quality-based volume. What that one does is the slide shows a year-to-year comparison of volumes for a number of our quality-based procedures using coded data available to November. For these grouping combined, there is a combined 10.268 case reduction, representing funding that has not been earned of 8.3 million. It's basically about COVID having to, they couldn't do those QBP volumes. While we didn't earn this revenue, the hospital would not have incurred the costs that normally are associated with cases of a similar dollar amount. So yes, you're not getting the revenue, but the cost to do the QBP volume is also, you save that. So it kind of offsets in some ways. Then the next slide is expenses, salary and wages. 10.4 million year to date, 1 million unfavorable in the month of December, and includes the following variances. COVID-19 screening of staff, patients, and visitors in the assessment centers is 543,000 in salary. Higher inpatient medicine and critical care staffing due to a surge in COVID-19 patients, which is 530,000. And net patient services revenue, medical staff remuneration, 2 million unfavorable. Medical and surgery supplies, where am I? Are favorable to date by 1.6 million due to the savings of 2.6 million in the perioperative program of the two campuses due to reduced surgical volumes. And that is what's happened is the surgical volumes have to be that are elective especially have to be set aside because of have to take care of the people with COVID. So, okay. This slide clearly shows the impact of 2 waves on our staff sick and isolation payments. You can see the uptick in December 2020 related to the second wave. Yeah. The sick pay to date is 612,000. Isolation pay is 734,000. While drugs are 4.2 million unfavorable to date, most of this variance has revenue recoveries, either from our retail pharmacies or from the Ministry of Health in the chemotherapy and renal programs. Other supplies, 609,000 favorable overall, with a number of line items where the favorable and unfavorable variances offset each other. An example, as shown on the slide, is unfavorable variance for minor equipment purchases of 1.5 million, offset by the surplus in the utilities for 1.4 million. Okay. And now we're doing the patient access. All patient areas, with the exception of OLET acute care, are at or slightly below their expected occupancy lengths of stay. And then okay. Just a second here. Patient volume. We have graph shows, oh, that's not a graph. You can see that basically everything is reduced in terms of patient volume, and that's understandable because regular surgeries, etc., have to be deferred. And okay, the patient volumes. The graph shows the year-over-year volumes to December and the difference. All are trailing behind the target except for community visits, as this includes 74,989 COVID-19 assessment center visits. There were 1,773 vaccinations given in the month of December 2020. So that huge amount is in the assessment of the COVID-19, the testing. 6 overtime and FTEs staffing. Compared to the previous month, sick and overtime were higher in the month, with the exception of sick time at OLET, which remains unchanged from the previous month. So the total FTEs for MET and OLET combined are 12.29 under budget. So that's my report, and I'm going to ask that someone. I'm going to say a motion, and I need a mover and a seconder.
So Penny, you're making the motion to accept your.
Yep. I move that the financial report with December 31st, 2020 results presented at the February 4th, 2021 meeting be accepted.
Perfect, thank you. I think I saw Lori Freeman's hand up to second that. Does anybody have any questions or comments with regards to the financial report? John?
Anthony, I just have a comment with respect to the organizational health, and I think that's pretty darn good considering what those nurses and what that staff and doctors are going through.
Yes.
I think that's remarkable.
Mm-hmm. Yeah.
Agreed. So can I get all in favor of that motion? I think that was everybody opposed. Seeing nobody. Okay, great. Thank you so much. Next up, we have the media report. That's for information only. I think everybody can get that. It's on the hospital website if you want to take a look at it.
Anthony, it's Cheryl. We have the consent agenda.
Yep.
Oh, sorry. I jump in the gun here trying to get this thing done with.
Well, I have a motion, and we get a mover and a seconder. I move, the motion is that the report from the January 25th, 2021 Finance Audit and Resources Committee meeting be accepted. Basically, it's the minutes of the.
All right, perfect. Seconded by Paul. Questions or comments? Seeing none, all in favor? Wonderful, thank you. Opposed? I didn't think there was anybody. Very good, thank you. Sorry about that. So next up, we have the correspondence. It's printed materials. So just a heads up for all our friends out in YouTube land or on Skype right now. There's a documentary coming out called Dispatched. You can get the link through the hospital Facebook page, and it outlines patient stories at the St. Clair Center. I almost said St. Clair Center for the Arts. Sorry, St. Clair Sportsplex. It's 90 minutes and it's airing on TVO. I believe it's on March 16th, but go to the Windsor Regional Hospital site for their details. Second thing is the February 50/50 draw is live now. So if you haven't got your tickets yet, please go on there and buy your tickets. The last person won $98,000, and it's helping fund hospital equipment purchases. So thank you everybody for your generous support in that regard. Any questions or comments from the board? Oh, David.
Mr. Chair, just want to thank, this is Monica Staley Liang's last board meeting before she leaves us February 20th. So just wanted to thank Monica for her years of dedication to the organization and also to our community, and want to applaud her and wish her best in her future endeavors. So you received a Zoom applause, Monica.
We'd like to be there to shake your hand in person, but thank you very much for all of your service. We appreciate it. You've laid a foundation of, see, this is why I don't go off the cuff. Great job. Thank you for all your hard work, and we're going to miss you.
Yes. Oh, thank you. That's it.
The date of our next meeting is March the 4th, same time. And can I get a motion to adjourn? We have Arvind and then John, all in favor. Wonderful. Nobody's opposed. So thank you, everybody. We will reconvene in approximately, I think we could probably reconvene in about 20 minutes. I don't know, David, do you think that's enough time?
Yep.
Okay, perfect. Thanks, everybody.